Hello, everyone. I'm Cynthia Charles, Vice President of Public Relations for the North Carolina Healthcare Association. And I'd like to welcome you to our virtual town hall conversation about the state of rural healthcare in North Carolina. We're so glad that you could join us today. And I'd like to give a special welcome to several members of the North Carolina General Assembly and their staff who are with us today. Thank you so much for your interest in this topic, and we appreciate you taking time to participate. This is the 9th statewide town hall that the North Carolina Healthcare Association has held in the past 2 years in an effort to make hospital leaders available to the public, to talk about current issues in healthcare, and to answer questions that you might have. We will start with a moderated discussion and then take some audience questions. A few housekeeping items. Lines will be muted throughout the program. You can submit questions for the panel using either the chat or the Q&A icon at the bottom of your screen. We have several pre-submitted audience questions that the panel will address at the beginning of the Q&A, and then we'll open it up to live audience questions. And now I'd like to introduce our moderator, Joann Anderson. Joann is a senior advisor with Ascendient, and she is the former chief executive officer at UNC Health Southeastern in Lumberton. So she has vast experience with rural healthcare issues, and we are in great hands with our moderator today. Hello and welcome, Joann.
Hello, Cynthia, thank you. I am joined today also by a distinguished panel of leaders across the state of North Carolina who also have great experience in rural healthcare and are going to add a great deal of insight as to what's happening in the rural space today. Let me start by introducing each one of them to you. I have with me today Bert, who's the CEO of Parham Health at Duke LifePoint Hospital, Dr. Roxie, who is a president and CEO of Cape Fear Valley Hoke Hospital, Paul Hamus, CEO of Hugh Chatham Memorial Hospital, Dr. James Hoekstra, President of Atrium Health Wake Forest Baptist High Point Medical Center, and Mark Gordon, President of Cone Health Alamance Medical Center. Welcome and thank you all for agreeing to be on the panel today. I am honored to be moderating this session today. I know that you have great insights and are going to have a lot to share with our audience today and give some great insights as to what's happening in rural North Carolina. But let's start by framing the need for building healthier rural communities. North Carolina has 80 rural counties that have health systems and hospitals, ensuring that residents can access care close to home. And that's very important. You know, one of the things that I've had as a goal of mine my entire career is to make sure that access in rural communities was available for those who needed it most. Many of those health systems across our state have developed innovative partnerships to support needed access as well. Today, we're going to talk about challenges that rural hospitals face and opportunities that will help us to continue to improve rural healthcare in our state. So let's dive in. The first question or topic that I want to talk about today is the role of our hospitals in our rural communities. Our hospitals are very important to our communities, as we all know. But I want our audience to understand where we believe the hospitals play a significant role in the rural communities. So the first question for our panelists is, are there unique aspects of the relationships rural communities have with their healthcare systems or healthcare providers compared to the state's urban centers? Mark, I think I'm going to call upon you first and let you speak to that if you don't mind.
Thank you, Joann.
Can you give us some insights?
I'd be happy to. So let me first just say that I'm happy to be with you. I've worked in rural hospitals in Kentucky, Virginia, and North Carolina over the course of the last several decades. And there are certain themes that run throughout those rural hospitals. And you've already said it quite nicely in terms of access being the most critical aspect of what we do. And in some cases, I think it is more of an access challenge, clearly in rural communities than it is in some urban communities, because there are more providers often in urban communities. It is not uncommon that from an economic development standpoint, one of the things that if you're doing economic development, people come and they ask a couple of questions. One, they're going to ask about your schools. Number two, they're going to ask, do you have a healthcare system or do you have a hospital? And the quality of your healthcare often determines whether or not you have individuals who will be interested in your community to come in and provide economic development opportunities. So that's clearly one difference that's important for multiple reasons in rural communities. It's different from urban communities where there are often other ways to provide that sort of access. Another difference is the relationship we have with the people of our communities. When you're in smaller communities, the intimacy of the environments in which you exist, you are in a more finite pool of resource. So it's not uncommon that the largest employers in town are your educational primary delivery system, elementary school, middle school, high school, the state. It might be one or two private employers. You might have a prison. And it's not uncommon that the top employer in town is a healthcare facility. In these days and times, it's not only vital for access, but it's vital for in some of the higher wage employment bases that are provided by these healthcare organizations are in fact nurses, physicians, technologists, individuals who are committed and loyal to our communities, want to stay in our communities, and are willing to get trained in opportunities and stay in our communities and grow those environments. So it's really critical for healthcare organizations to be steadfast in partnership with our local chambers of commerce, with our local community colleges, and other key anchors in the community in order that we stay vital in order to keep our rural communities vital. It is essential. And it's not uncommon that in our rural communities, the rural hospitals and rural healthcare organizations have been in a crisis for decades. And to no one's surprise, and it's not new information, many healthcare organizations in rural areas have been challenged financially for a long time. I would say that there's more rural facilities that have been challenged for a longer period of time than in some urban environments. And we are now, due to COVID and the surges that we've come through, I would alert all of us by interest of being on this call today, this WebEx, that pay attention to the resiliency of your local healthcare organizations in rural communities. Urban environments are challenged in this time. Can you imagine what's going on with our rural facilities from an economic development point and their ability to sustain themselves through these challenging times? So there are so many things that differentiate a rural community from an urban community. And I would just mention one other final thing, and I think it's important that we look at the context around some of the larger scope of things that are going on. And I would mention around our provider base, physicians in particular. When you start looking at physicians and the provider base, it is not uncommon that rural communities in different states across the nation have been more dependent on foreign medical grads. And given our immigration conversations and conversations over the last several years in particular, that has been disrupted to a degree. And I would ask that we reflect deeply over time around these larger issues that may seem a bit distant, but they really are more important to the rural environment, because if we upset the balance of that provider base, that resource, it really does challenge access issues in the rural community. Given that we have both nursing and physician challenges in terms of provider base, is something that we really need to pay close attention to.
Thank you, Mark. I think we're pretty extensive in terms of the issues that you brought forward. I'd ask if there are anything else that any other panelists would like to add to this particular topic.
Joann, I think, if I may, Mark, his response was right on. But one of the things we talked about the differences, but I think it's important that we mention the expectations that are very similar. For example, we are expected to improve health of the population. We're expected to promote health. We're expected to prevent illness. We're expected to provide post-discharge support. We're expected to allow high quality care close to home. And so those things are very similar to what you would see in an urban area, but we have to remember, to Mark's response, that we are under different financial pressures from different areas. And so we have to remember, not only are we different, but we're expected or we're held to the same standards, which we should be when it comes to quality of care and the care we provide and what we expect our clinical outcomes to be. And so I didn't want the audience to miss that part of, although we have different challenges or different relationships with our community still expects us to provide high quality care close to home, to make sure that they're healthy, to decrease or to increase or make outcomes better. And I didn't want our audience to miss that.
Yeah, and I think one of the points that Mark made that I want to stress is that in the rural communities, the hospital that's there is usually the only hospital in that community, serving that community. Our urban peers often have multiple opportunities or different access points for different hospitals and health systems where there's only one in that rural community. Anyone else have a comment you'd like to make?
Joann, this is Paul. I'd like to add to what Mark and Dr. Wells have said. Excellent comments. And, you know, I've heard that you have a three-legged stool in a rural community. And the legs are constituted of education system, of the faith community, and healthcare. The smaller the community, the more conspicuous that role is. We're talking about it already. Hugh Chatham is in Elkin, North Carolina, in the foothills. We have about 4,000 people who live in Elkin, about 10,000 when you look at the greater area with contiguous zip codes. We provide 1,000 jobs, $50 million annual payroll. You think about how a dollar cascades in a community. That's very meaningful on a small scale. And these are good, meaningful, rewarding jobs and careers. There are 2 hospitals in Surrey County, Hugh Chatham and Northern Regional in Mount Airy. And healthcare jobs have the highest average wage when you look among the sectors. So allowing people to have an opportunity to support their loved ones, to have a career without leaving is a big deal. Of course, many of us are nonprofit organizations, and we provide care to all regardless of their ability to pay. That's a huge component of the value a community hospital provides in a rural setting, where you may have higher unemployment rates, a different insurance mix, if you will. And, you know, last year we wrote off about $30 million in charges associated with care for people who really needed it, but couldn't afford it. And so that's another important part. And I think Mark mentioned, you know, that we're engaged in our communities. We're very involved. The cloth of a community fabric is very tightly woven, but you can discern the individual threads, and we can never forget about that opportunity to influence the community's well-being, you know, by serving on boards and other organizations. I have to share 2 quick anecdotes that when I thought of the most important way to articulate the value of a community hospital in a rural setting, these 2 experiences I had this morning. I was walking into the office and I was getting ready to open the door, and I heard this, eruption, a joyous eruption from down the hallway. And I thought, well, that's unusual. I want to see what that is. I'd like to be a part of that, actually. And then I remember I also heard a bell ring. It was a cancer patient being celebrated for completing their treatment. Mm-hmm. Rural community hospitals make available life-saving and vital care so that close to home, close to loved ones, individuals can get what they need. That's essential. The second thing is allowing community members to participate in what we do through volunteerism. And I ran into a volunteer this morning, rounding. His name is Jacob. He has a sister who actually works here, and he's a very special member of the community who actually has Down syndrome. Jacob was wearing his Hugh Chatham polo shirt, freshly pressed. He had his badge on, and you could feel the pride radiating off of him as he told me about what he was going to be doing today working in the gift shop. How meaningful an experience we're creating for Jacob and all the other volunteers too, to be involved in our mission. So thanks for letting me chime in.
Thank you, Paul. You know, we can't talk about rural healthcare and some of the challenges that you're facing today without talking about the challenges you've faced over the last 2.5 years through COVID. I was right there with you during that 2.5 years. I just retired in December, so faced that with you, and thank you for your leadership during that very difficult time and the time as it continues. This was an ongoing, sustained pandemic that most of us, I had never been through before, anything like that, and I think probably you had not either. But with that, it also opened up some opportunities. But I have 3 questions that I'd like for us to consider for the audience today that I think might be meaningful for them. When we talk about the rural hospitals in North Carolina and how they're faring today, the pandemic definitely impacted rural healthcare just as it did our urban counterparts. And we were heroic in doing it. But what are you facing today in terms of financial and operational impacts from the pandemic? Are your operations and staff recovered from the impacts that you saw during the pandemic? And then what should our listeners know about the current operating environment for our rural hospitals post-pandemic, even though we're not completely out of it yet? And I'm going to start with Dr. Hoekstra and let him address that.
Thanks, Joann, and thanks for inviting me. I'm going to be speaking not just from my experience at LifePoint Medical Center, which some of you may not consider to be particularly rural, but also Allegheny Memorial Hospital in Sparta, which Paul and I share leadership at. And let me start by saying, before we get into the effects of the pandemic and on us in multiple different ways, and it has been absolutely transforming. Let me also utilize the pandemic as an example of why our rural hospitals are so important. So it wasn't that long ago. We're talking just back a few months in the middle of January when we were hitting the highest peaks of admissions to our hospitals for COVID. You know, I had about roughly a third of my beds were full of COVID. I know the rest of you had lots and lots of patients in them. At Allegheny up in the mountains where the inpatient census, you know, typically runs a couple a day, every single bed was filled in the emergency department, every single bed in the observation unit on the inpatient side with COVID patients, some on ventilators. They were providing an invaluable service to that community. And those patients couldn't be transferred anywhere because nobody had space. So they were out there being the front line, supporting their communities, okay, and essentially providing a perfect example of why rural healthcare is so important in this state. The stresses that were put on the healthcare systems, especially on rural hospitals during the pandemic, are actually continuing, and we have significant stresses remaining. A lot of it having to do, frankly, with staffing. And if you think about it, that stressful situation for 2 years where we had peaks and valleys in the number of patients, the acuity of our patients, where we had the inability to be able to interact with our communities because we were all locked down, or because we couldn't have meetings, or because we couldn't have visitors in the hospital. And that time of stress on our staff really takes a toll on any organization, big or small. And we've all suffered through probably the biggest change, which is the changes that we've had because of the Great Resignation, if you want to call it that. We've lost a lot of providers to retirement. We've lost a lot of providers to going to different areas of the country to travel and earn more money. We've lost a lot of providers and staff to burnout, if you want to think of it that way. And what we've been left with is a situation where we've had to hire a lot of what we call travelers or contract labor to make sure we keep our missions running. And we've had to change our care models significantly to make up for the lack of bodies to provide that service. And they cost more. We've also had to pay more to keep them because we didn't want them to leave. So what we've been left with, and I'm sure everybody in this Hollywood Squares can tell a story right now, and hopefully they will, what we've been left with is less staff, more overburdened, and more expensive. And in a situation where coming out of the pandemic, when we want to be able to start to grow and work and get back to what we would call normal volumes and normal care, we're all struggling with significantly higher cost. to provide that care, much more of it on the staff and provider side. It's been very stressful for us for that reason in rural healthcare as well as inpatient care. We have developed a lot of models that are really important for us to make it through that. You know, during our peaks, we were sending patients home early and providing essentially care in their home, something called the hospital at home program. We've developed telemedicine, which I'm sure we'll talk about later, to provide critical care in rural locations where it typically hasn't been provided before, because now all of a sudden we have to. And a lot of those things may actually have good long-term effects. We've also changed significantly what can best described as our ability to communicate with our patients because of that as well. The good news is that rural hospitals really stepped up. Rural hospitals showed how incredibly important that they are, but rural hospitals are hurting even more than they used to be. As Mark mentioned, this is a multi-decade stress on them, but they're still hurting from that financially because of what's left after COVID in terms of our staffing and supply chain, and everything costs more than it used to, but we're not getting reimbursed anymore. Makes it a very tough situation on a moving forward basis. I'm sure other people can chime in with similar stories.
And I'm sure there are stories from each of the panelists and many of the people that are on this WebEx today who have had that experience as well. You know, I think from the rural perspective, going through the pandemic, we were there for the communities, doing everything we possibly could, including outpatient services that are not traditionally provided by hospitals, and providing a lot of public health education that was needed to get the public involved in their own self-care and that type thing. And again, that's going to be somewhat ongoing going forward. And we've learned a lot from that. I think with that too has given us some opportunities potentially coming out of that for growth in things that we learned through the pandemic. And I'm going to ask Bert if he can talk to us a little bit about what our rural facilities, what opportunities we have today for growth coming out of the pandemic. What are some of the challenges that we're facing? And then how are we working around those challenges to make sure that access is there?
Thank you, Joann. Ultimately, I think we have to address some of the challenges on the way to growth. I think it's been referenced, just integrative efforts are more important than ever within our communities, working with our local community colleges, our STEM programs at a high school, getting young people interested in healthcare, and as important as it is as a career choice, but understanding intrinsically what it means to serve a community in that capacity. Those are critical elements of how we're going to dig our way out, so to speak, on the workforce issues. And then through that, really looking at how we remain relevant. Here at Mariah Parham, we're fortunate to have partners in Duke, and we've partnered on, family medicine rural track residency program that we think will serve the community for years to come and serve as a model for how we address provider shortages in rural communities. And we're looking at other important foundational specialties on how we would expand that in partnership with Duke. So we're more fortunate than a lot of rural communities to have those type of partnerships and that proximity to be able to pursue those things. Having an we've initiated an interventional cardiology program. We've initiated inpatient behavioral health, which is more relevant than ever. But the challenges that face us and face all of us in rural communities is, how are we going to fund these programs and critical services, and how do we address this societally as an ecosystem? We make a lot of decisions in policy that seem to be made in a vacuum. And a couple of examples for that are our Medicaid expansion and our managed Medicaid play. So we're seeing increased denials and more difficulty getting access to funds. And we're one of 12 states in the country that hasn't expanded Medicaid. And we know, based on our company's experience, because we're part of LifePoint and we've operated in 30 states, that the urban centers do not have as negative an impact as rural community hospitals. We tend to see in states that in states that expand, tend to have nobody has regrets on expanded Medicaid relative to that. Another issue that I contend is a big one that gets addressed every year in the legislature is CON reform and repeal. We know, again, based on our experience in other states, that rural health systems see a negative 7% margin impact. Now you stack that on top of the factors we're dealing with now, and the statistics that I've seen recently that show about 55% of our hospitals across the state are operating at a negative margin. You're going to bury some of your health infrastructure. When you think about that in whole, in totality, our urban centers, every hospital was overrun in terms of staff bed capacity. If you start to see hospitals shut down, you're just going to overwhelm those urban centers as well, and they can't build bed capacity fast enough. So, ultimately, I think how we stay relevant within evolving healthcare is important. We have to be mindful of the technological advancements that the pandemic kind of thrust upon us. Telehealth is a great one, but how we pay for that and how we pursue fair payment based on setting is critical. So I think there's a pathway there, but we can't continue to make decisions in a vacuum. And workforce challenges as they sit right now are not sustainable for many of us. At the end of the day, I think we're a very progressive state. I think the growth we have in the state across all industries is fantastic, but that's also challenging healthcare infrastructure. So we have to be mindful of that. I mean, as it stands, we are on the bottom half of the country in terms of nurses per 1,000 people. That's significant. So we're going to have to think of creative ways to care, creative care models. Team nursing is an option. And looking at how we promote and secure and restore the pipeline of caregivers for years to come.
Okay.
Joann, if I may add, just jump in here a little bit, I think it's important that we add a little bit of context to what Bert has said and what Dr. Hoekstra has mentioned as well with regards to growth and sustainability. When we look at North Carolina and not just rural hospitals, but safety hospitals and hospitals in general, but particularly in rural hospitals, when we talk about labor expenses, workforce shortages, all the things that they have mentioned, really at the end of the day, it affects the bottom line, which impacts our ability to provide care. And, when you think about the statistics, 2/3 of, as Bert may have said, 2/3 of our hospitals are operating in the red. Greater than 75% of our 49 rural hospitals are operating in the red. A survey was just released not too long ago that said 18 out of the 49 rural hospitals in North Carolina are at risk or at increased risk, immediate risk of closure. The median operating margin for most hospitals in North Carolina now is a negative 3.7%, not positive, but negative 3.7%. When you look at our expenses are up greater than 10%, while our income is only up about 2%. When you think about the fact that we haven't raised our rates as other businesses have, passed on increase to customers, which we don't do. We have fixed payments from the government and commercial insurers. We have struggling hospitals that are dipping really into their savings accounts just to pay bills. And when we think about how that compares to the general public, individuals want to have some sustainability, and I think hospitals need it as well. And so therefore, when we look at the context across North Carolina regarding the things that Bert talked about, things that Dr. Hoekstra talked about, there is concern. And I know that we have some of our General Assembly leaders on today, and I appreciate that. And I'm thankful that they are interested in hearing about our concerns in our rural hospitals.
I'd like to follow Dr. Wells and add a little bit more context if I could. I'd like to pull out, we've implied it. I like to punctuate on a common thing that's happening in rural communities, and that's that we have a disproportionate share of the aging population. And we've implied it, but I think we need to really say it and think about what's happening here. We are aging rural. We have flight to urban areas by our younger populations. We've got people in place in rural communities who are aging a little bit faster. And we've been talking about this for about 20 years now. It's not going backwards. And the result of that is that many of those people are Medicare. So that is a part of our payment base as a fixed population. In addition, in rural communities, we have less to our colleagues, fewer skilled nursing beds and other support services. So when those individuals are admitted to our facilities, we have fewer resources to which to discharge them. So they oftentimes have longer stays in our facilities, which is sometimes not the best place to stay for them, but also at an increased price to both the individual and to the community. So that's another pressure that's different than urban communities. It's a pressure in the urban communities, but it's more of a pressure in the rural communities than it is in the urban communities.
If I may too add to what Mark's saying, because some may hear that and it leads them down the path, well, we should do away with CON and let free market reign to put more services in those facilities. And Mark's 100% right in what he's saying. The issue with doing away with CON, and I want to emphasize this, is we have to play by a different set of rules than independent players if you're operating an acute hospital. And that's under EMTALA, which I won't explain here, but we're obligated, as everyone on the panel knows, to provide 24/7 safety net services. And why free market economics, while I'm a fan of in every other industry, should not apply to healthcare is because as a society, which makes us great, we have dubbed that some level of healthcare is an inherent right to being born or residing in the United States of America. And we have to remember that. When you talk about imaging centers, they don't have to stay open 24/7. They don't have to give everyone that walks through the door their services. When you talk about other ambulatory surgery centers, same deal. I mean, I would liken it to a bank doesn't have to give everyone a loan that walks in because they want a loan. We have to offer that. And that's what makes healthcare great in America. And we have to remember that when we talk about even modifying or piercing some of this legislation that will protect rural health. And in North Carolina, we have the third largest rural population in the country. So I just want to, I think, Mark, everything you said was dead on, but I don't want people to get led down the path of, well, let's just open it up and let anybody build those services. That will put us under. It will impact us from a workforce standpoint, and it'll take all the payers that have anything that support our safety net services, and all you'll be left with is 24/7 urgent cares.
That's well said, Bert.
Yeah, well said. I agree with our panelists on everything they've said. I think there are two other things that rural healthcare is facing, as are some of our urban partners, but behavioral health is a huge issue, and we could talk for days about the need for behavioral health services and the challenges that are facing across our state related to behavioral health. But know that in the rural space, that is huge. Those two are people who often end up in our emergency departments and stay there for days and days and days, sometimes months, looking for a bed, as well as the health equity issues that are prevalent in today's media, for sure. We hear a lot about health equity. And when you look at the aging population or the demographics in our rural communities, health equity is difficult to accomplish. And we saw that played out significantly through the pandemic. I think that's one of the things, again, that may be for a future conversation, but those two are certainly important issues and challenges facing our rural communities. In the interest of time, I want to switch to some of the questions that have come in from our audience to make sure that we give them an opportunity to hear from us. We've touched on a lot of the things that I had hoped that we would touch on today, but they've brought up some significant questions that I think are important for us to spend a few minutes on. And we've touched on some of them already, but the first question that I have from one of our audience members actually came in prior to today's session. We had Maria O'Neill from Reedsville who submitted a question asking, do rural hospitals view hospice and palliative care programs as a help or a hindrance, and why? Hospice and palliative care.
They're a definite help, in my opinion.
Okay.
When you're looking at issues, particularly, again, this is a continuation of the conversation of the population we serve. particularly at the stages where we have more of a share of a aging population, which implies to a degree that you're dealing with some chronic disease in that population. So the congestive heart failure, all the oncology populations, orthopedic populations that have longer term need care issues, those individuals are making independent decisions around what they want to have happen with their lives in terms of their customer voice and their patient voice. In those kinds of situations, hospice and palliative care are the services exactly that you need in those communities to provide the appropriate level of care to those patients. Absolutely. And in some cases, hospice and palliative care is more needed in a rural community than it is in some urban communities.
Joann, I'd like to add to Mark's comments. I completely agree. A lot of the answers to a lot of the questions are, we have got to figure out how to integrate the healthcare system in a way that eliminates waste and inefficiencies, but helps us manage patient populations using evidence-based best practices specific to that population. We've done that for years around patients like stroke patients and heart patients. I did see something that we'll probably get to in a little bit around the cost equation. We are not doing acceptably. We need to do more to find ways to make care more affordable. And that has got to be focusing on the 5% of patients that generate 60% of the cost in America, in the healthcare system. This is germane to those thoughts and around hospice. It's a better way to provide care to patients who are at the end of life and to support their loved ones who are before, during, and after death to cope. And I want to, if I can briefly share something that we've done here locally.
Sure.
Is we actually have a joint ventured hospice organization, Hugh Chatham with Northern Regional, based out of Mount Airy. And we formed it in 2005 with the thinking that instead of, competing with one another and replicating a lot of resources, we could do more for our community by joining forces and our wherewithal. And today, we're across 18 counties in North Carolina and Virginia. We have a hospice home, the Waltz Hospice Home in Dobson, and CQ Hospice Home in Yadkinville. And last year alone, we had 140,000 hospice patient encounters, including in the homes and also at home. And nearly 400 team members count on us for a livelihood. So there's a huge demand for it. It's been growing, but here's what I got to share. We need to think about how we view hospice culturally in this country. The old way of thinking is that we got to do whatever it takes to keep a loved one alive, even when the efforts are clinically futile. And I saw a recent survey that indicated 80% of Americans would prefer to die at home. Yet those wishes are fulfilled for only 20%. And half of Americans in their last month of life receive care in an emergency department. That we got to change the culture around how we partner with hospice, how we integrate it, and how we introduce it and educate our communities around the value and importance of that service, which is a relatively low-cost service. So it's very, very vital. And thank you for letting me share some thoughts there.
So I agree 1,000% with Paul, and I've got to just chime in because I think there's the misnomer, and the question highlights the fact that I think a lot of people think hospice and palliative care is giving up, but what it really is preserving a person's humanity and dignity and helping the family move on with them there. And I think that is longstanding, and in certain rural, certain rural sectors, there's a strong culture behind that negative perception that we have to figure out how to combat.
Yeah, I want to add to that also. With regard to hospice, we've often talked about regionalization of care. What should be provided in a rural setting? What should be provided in a big city or big medical center setting? And hospice is so much better administered at home, meaning it's got to be rural. We've always talked about primary care and urgent care, and some of the specialties like orthopedics and cardiac, where you really want to have that in a rural setting. Hospice is probably more important than those to be rural, because it's got to be provided in the home where the relatives are in that rural setting. And so what I agree with both Bert and Paul with this, and also just want to, emphasize location is rural.
Right. Exactly. We've had several audience members who have submitted questions asking what rural hospitals are doing to navigate staffing shortages. And there's another question that tags into that came from Stacey Yancey from Asheboro, who said, how do you see allowing providers to practice to the full extent of their education and training as a way to help rural hospitals? I think those two topics go together. I'm going to call on Dr. Wells first, because I know Cape Fear Valley is addressing provider shortage for the future through a new construction project that they have going on for medical education. Could you give us a little bit of insight on that? You're muted, Roxie.
I'm sorry about that.
That's okay.
I think it's an important question. The workforce has been an issue for us for quite some time. It didn't really just start with the pandemic. It was exacerbated by the pandemic, obviously, but we had concerns before the pandemic. And so here in our region, Cape Fear Valley, several years ago started residency programs and working with our local medical schools. And so in the fall, we are set to open a state-of-the-art center to accommodate our growing educational programs. And that center will include expansion space to house any additional programs we might have. And so when I look at what we're doing and why we're doing it, I look at it kind of in three buckets. One, from a care perspective, we want to improve health and health outcomes for our region by increasing the number of patients that we can see, by increasing the number of providers. And then secondly, we all know that a teaching hospital is a learning hospital, and you end up with cutting edge technology and methods of care, research opportunities increase. And so that's important. So that's one bucket. And then I look at the economic bucket for our Southeastern North Carolina region. Our studies have shown that this center stands to generate over $500 million in economic impact for this entire region. And then last but not least, from a workforce standpoint, we anticipate adding hundreds of new physicians to this Southeastern North Carolina, with over 300 residents once we reach full potential, hopefully this coming year. And really just thinking about 25% of our counties in North Carolina don't have an OBGYN, they don't have pediatrics, they don't have general surgery, they don't have psychiatry. And a lot of those counties are in the far western part of the state, and here in the eastern and southeastern region. And so what we do know from the Association of American Medical Colleges is that when people are trained in a community or trained in the state, 68% of people who are trained, who receive medical training, stay in the state in which they're trained. And then greater than 50% of those live within a 50-mile radius of where they're trained. And so if you think about what's happening here in Fayetteville, it impacts Sampson County, Robeson County, Bladen County, Hoke County, Harnett County. And so we stand to gain a large population of physicians for this area. And then someone asked the question, did I believe that people should work to the top of their license? I believe everybody in healthcare, no matter what your job is, whether it's the lab, whether it's caring for patients or what have you, should work to the top of their license.
I'd like to extend Dr. Wells's comments to the right on this money comment around staying local, because I think one of the responses to staffing is retention and keeping people from leaving. But when we start talking about that, I'm going to shamelessly plug our community college system and the rate limiting step of our community colleges competing for faculty positions due to salaries, particularly nursing faculty. So I'm going to shamelessly plug that one of the rate limiting steps for developing local nurses who come from that community and will stay in that community is that we need to support faculties at community colleges so that we could increase the maximum number of candidates in that nursing class so that we can keep those individuals and those dollars circulating in our local communities. So I would say that there's longer term strategies that I would ask that we come together and really focus in on how we could actually keep these individuals in our communities as well as the dollars that they work for.
Thank you. We also have a question from Dorothy Carnes from Wilmington. Dorothy asks, what investment in rural health would have the biggest bang for its buck? Great question.
Oh, well, I certainly don't mind, don't mind starting. I think we've talked about telehealth. I think that is a huge investment, and certainly we need broadband coverage in all of our counties. So that would be a huge investment. Workforce capabilities, as Mark stated, our community college are exceptional ways for us to develop the workforce that we need, and not just nursing, but physical therapy assistants, imaging,
Technologist, pharmacy tech.
lab, to everything. That would be a wonderful investment. And then the last thing I would say is that, when we talk about investments, we definitely need to think about expanding Medicaid. I think that's a huge investment because it covers everything, right? It gives us additional funding. And then the second piece is the average commercial rate program that CMS has, being able to draw down those funds that would help North Carolina hospitals. And I know we may talk about that a little bit later on, but I think that that's extremely important. We're talking about over $3 billion that could come to North Carolina just by our General Assembly really requesting that we be able to draw down those funds. And it really doesn't cost North Carolinians anything, but it sure would be helpful for our hospitals to be able to obtain those funds and use them for fixing outdated buildings, having services, strengthening the workforce, and so many other things. So I think those are a couple of things that I would say would get us the bang for our buck.
I think a good bang for the buck would be our hospital at home program that we are advocating for. I mean, it would tie together a solution to several challenges that we have. Limited number of beds, opportunities with staffing, keep people at home in place where they're familiar. And so the current conversation that we're having around how we really address that conversation, and as a lesson coming out of COVID, I would advocate for one of the considerations, biggest bang for the buck, is to continue to really think deeply about implementation and follow through on hospital at home.
Okay, all of those kind of feed into the telehealth, telemedicine initiative. There was a Senate bill or a House bill last year, House Bill 149, that the Senate could consider next session, and it has to do with requiring health insurance plans to cover care provided for virtual visits. Why is that important?
If you don't mind, Joann, I'd love to take this.
Sure.
This is especially important for rural hospitals and rural health provision. We've had. I'll just give you a for instance. This is how we used to do it versus how we can do it. So specialists are in short supply in rural hospitals or rural health systems, no doubt about it. Cardiology, cancer, orthopedics, neurology, critical care, a number of things like that. The old method of taking care of that was to send a cardiologist on a 2-hour journey up the mountains to a rural hospital to spend a day seeing cardiology patients, then drive all the way back. And they're only up there maybe 2 days a week.
Right.
But it's incredibly wasteful. It's hard to keep people doing that long term. It's just not an efficient way to providing care. Doing it by telemedicine requires no travel, requires nobody to change. It's easy to do it from home, and yet the experience is almost exactly the same. You can do that in so many different things. We do it in virtual critical care. We do it in virtual neurology, virtual telepsychiatry. If the billing mechanism is taken away for that, it'll go back to the old system.
Yeah.
Okay, and that puts a lot of the quality of care that we're providing in rural health systems at risk. I mean, every day we're doing telemedicine to rural hospitals to provide consultation, to provide, virtual critical care. Those are imperative for the success of those rural health systems long term.
I'd like to add to Dr. Hoekstra's comments and talk about a specific cohort of patients who need our help and need it now. And Joann, you mentioned we get to have a whole session on behavioral health and mental health and wellness. But it's important for everybody to understand, first of all, there is a dearth of supply when it comes to psychiatrists and behavioral health professionals in general, let alone in rural settings. Over the last couple of years, surely in part due to the pandemic, for a lot of reasons, there's been a 25% increase worldwide in anxiety and depression diagnoses. That's according to the World Health Organization. This is the most alarming thing to me, that in the US, the American Academy of Pediatrics has declared a national emergency in children's mental health. And part of the reason why is that compared to 2019, in 2021, there was a 50% increase in emergency department visits for suicide attempts among girls aged 12 to 17. 50% increase. A third of the involuntary commitment patients who present at our emergency department who are at risk of harming themselves or others, a third of those are pediatric aged. And we've seen an overall increase of 65% in behavioral health patients presenting in our emergency department. It's been referenced. That is the last place where a behavioral health patient needs to receive care. We can't do it in the rural emergency departments where they board for days and weeks. We're doing them a major disservice. We need increased federal and state funding to train and deploy additional behavioral health specialists. And we need improved access to and reimbursement for behavioral health telemedicine. And that's to the question. We've got to make that the primary clinical intervention tool because we don't have the people to do it. And the last thing I want to say is a lot of this conversation is, at least by way of inference, pointing upstream of the current problems we have. We have got to get into the high schools and middle schools and elementary schools and find the right way to have a conversation to continue to destigmatize mental health issues. We have to do more. And part of the problem is today, and I've been involved in some of these conversations locally, the students understand and feel safer raising their hand and saying, I need some help, okay? Or answering a screening tool honestly. The part of the issue is that for their parents, it would be considered an embarrassment for them to have to get behavioral health care. It would be a scourge on the family. We've got to do more there. But back to telemedicine, behavioral health is a huge, huge priority. It must be a huge priority.
Joann, if I may add.
Go ahead, Roxie.
Thank you. If I may add, I agree with all of those things, but I want to add one other thing. We need to be sure that we're looking through the lens of equity as we discuss each of these issues. It's extremely important. Mental health, extremely important to look through an equity lens for sure. And the other thing is to talk about, as Dr. Hoekstra said, we were able to stand up critical care here at Hoke, and it was very helpful. We couldn't send anybody anywhere. There were no openings, no beds anywhere. And so we had to figure out how to care for high acuity patients that we typically didn't care for. And that telehealth piece really helped us. And so we will continue to use it. And so payment for that would be appropriate. But the only other thing I would say would be all of the things that we've discussed, we definitely need to discuss them through the lens of providing equitable care.
I just want to tie together the last question and Paul's comment about telehealth and behavioral intervention. And that is it's not, people don't automatically draw the connection that if we have that telehealth support, we can actually keep individuals who come in with perhaps, not that this is exclusive, violent tendencies to our EDs, where we are having nurses and others who are leaving the workforce because of the amount of violence that's taking place in our facilities. So I just want to draw that indirect connection that telehealth actually could have a positive impact on our workforce.
Great. Thank you all. We're down to our last few minutes for our session today. So I have lots of questions that I could throw at you from the audience. They're very interested in what you have to say. You've provided them with lots of information, lots of things to think about. But I'm going to end with two questions that I'll throw out to you. The first one is from someone live in the audience at this time, which says, what types of partnerships are you considering to better enable you to provide needed services to the community or to do so in a more financially sustainable way? And I think we may have touched on that already, but can you talk just briefly about some partnerships that you believe are going to help us be more sustainable in the rural community, but also be more cost effective?
So I think that's another differentiating factor in rural communities, in that collaboration, in order to be sustainable in rural communities, you have to have a high collaboration skill. There are other individuals, and I'll take Alamance County as for instance. We have other providers who are not necessarily in the acute care space. They're home care providers. They're providing primary care services. There may be independent practices. But in the rural space, it's incumbent upon us to find opportunities to partner in creative and innovative ways that sometimes it doesn't necessarily require that in the urban community environment. I think looking at ways that we can really lean into this conversation of value-based care and taking care of patients over the horizontal continuum is more of a conversation in the rural community, because we don't have those resources necessarily that we can take care of people in one site at one time. But I think those kind of collaboration in rural communities is an essential.
Anyone else have anything you'd like to add to that?
And Paul and I are looking at each other, probably smiling back and forth. Who's going to go first, you or me? But I also think it's incredibly important, given how difficult it is for a rural hospital to remain competent, to sustain competency in many different high technology fields and highly regulated fields, to partner with a larger health system to do that, because the economies of scale are pretty hard to obtain unless you do that. And sometimes it's incumbent to be able to find what I would call innovative partnerships to allow sustainability for those rural hospitals. We've had a wonderful situation where we've partnered together to help Allegheny Memorial Hospital. I'm sure there are other people on this Hollywood Squares who would say exactly the same thing with regard to Duke or Cone or whomever. But those partnerships, I think, are important too.
Great. Bert, did you have something you wanted to add?
Yeah, I think locally, thinking non-traditionally, partnering with the school health system, to Paul's comments around mental health in children. How do we create awareness and preventative structures to get ahead of that, to talk about healthy living, and in many cases get into not just the physical well-being, but the social and mental well-being of what's going on. So, partnering with the Boys and Girls Club, talk about how they evaluate mental health in children, getting with the schools to make sure people are vaccinated. And some of that was strengthened and reestablished in the pandemic, where we would do drive-through vaccination events using school nurses and hospital staff, because in our community, I don't have a bevy of staff or the critical mass to pull people away.
Right.
So looking at those structures and how we take that forward, not just in a crisis, but to really get ahead of managing social and chronic disease potentials and mental health in a way that can curb some of the negative trends we see from a health standpoint. Thank
you. So I have one last question, and it comes from one of our friends in the news media. We have a question from Clarissa Donnelly from the North Carolina Health News. She asked, what gaps do you see in news media coverage of rural health in our state? Are there important issues, positive stories, or important context setting issues that journalists covering rural health should ask? So we have about 1 minute left. Who wants to take that? We'll have the opportunity for one person. What do you want them to say about us?
Well, I would definitely like them to say that rural North Carolina has some of the best people in the entire state, and that they want what others across the state want: great health care, access to good schools, and all of those things. And so I would recommend giving that type of coverage to really express what rural North Carolinians would want.
Thank you, Roxie. I would just add to that, we're coming to the close of our time today. I want to thank everyone that's been on the session with us today. For those of panelists that are here, you did an amazing job. We had touched on a lot of different things. To the question that we just answered, that Roxie just answered for us, I'm sure that if you had any questions from the news media that you would like to have answered, anyone on this panel would be happy to talk to you about that. We love rural healthcare. It's a passion for us, and we're here to serve those communities and to make sure that they get the best healthcare possible. So use us as a resource. We'll be happy to provide answers for you, to present questions to you, or to offer suggestions in any way. Again, thank you all for being on our panel. Thank you, Cynthia, for pulling this together, and NCHA staff. Thank you to all of those who attended today, and have a great day.